And honestly, it's such an honor to be able to kick off this session dedicated to LAMS, going beyond the standard indications, and to share with you my story of its development. It consumed over 10 years of my life, but I can tell you there was never a dull moment. I did spend most of it working with engineers and in the animal lab, but it was exhilarating. And you're all familiar with this quote, "Necessity is the mother of invention." It's from Plato, from the Republic, 380 before Christ. And in 1992, I had just arrived in Hamburg working with Nib Sahendra. And we had a patient with a non-bulging pseudocyst. So we were draining pseudocysts, but a requirement was that they be bulging with a prominent bulge for endoscopic guided drainage. And Pentax had just delivered a prototype curved linear array echoendoscope, and we were doing our very first fine needle aspirations with that scope. But it was Nib Sahendra who thought about the possibility of self-fashioning a needle that would allow us, with diathermy, to enter into the pseudocyst under EUS guidance. So we made this needle ourselves, a continuous still wire inside of a catheter sheath, and hooked that up to cautery. And then, after we entered into the cyst and passed a guide wire, we exchanged the CLA echoendoscope for a duodenoscope, and then we placed a 10 French stent to drain the cyst. And here you can see some of the pictures from the world's very first EUS-guided pseudocyst drainage. And this was really the beginning of this fascinating era of EUS-guided therapy. So the over-the-Seldinger technique, which radiologists use in their daily practice, we basically borrowed that from them and we applied it for this procedure, consisting of these 4 steps. We access either with an FNA needle or a cystotome, we insert a wire, we dilate the tract, could be a balloon or a bougie, and then we place a stent or stents or nasal cystic catheter for drainage. The problem is the Seldinger technique was designed by Sven Seldinger, a Swedish radiologist back in the 1950s, for the interventional radiologist working a very short distance to the target. We're working a very long distance to our target through our endoscope, so we have many more challenges. It is a multi-step technique, and because of that, it's also multi-risk. With each of these steps, we take some risk. So after we puncture the cyst or the cavity, pass our wire through the needle, and then remove the needle, we now have created a gap, a step-off, between our wire and the tract, and this can result in leak. Then when we insert a dilator over the wire to prime the tract for later stenting, there can be displacement of our target. When we dilate this tract over the wire, there can be perforation. And when we remove our dilator, now we've created an even bigger hole, a bigger gap between our wire and the tract diameter. Again, risk of leak. And finally, even when we place our stent, if there is non-adherence or poor adherence, then we may push the target away from the bowel wall. And this is a video from 2006, and I can tell you I'll never forget this. This was the moment that inspired me to think about what we need, the solutions that we need. This is a patient, I placed a stent, I thought everything went beautifully, and then when I looked more closely, you can see the mesenteric fat sign, what we all fear. This was a perforation, and I'm looking outside of the gastrointestinal tract, outside the cyst that I had intended to drain. This patient ended up having to go to surgery, had a number of complications after surgery with a not so pleasant outcome. We must remember that when we perform EUS-guided transmural drainage, it is an intentional perforation of 2 walls, the bowel wall and the target wall. And if there is poor adherence or no adherence, such as the gallbladder or the small bowel, as you just heard, there's a significant risk of leak. Here's the gallbladder. You can see there's an echogenic layer between the gallbladder and the duodenal lumen. That echogenic layer is fat. That is because the two structures are not adherent, even though it looks like the gallbladder is adherent. And this patient went to surgery because of a leak, and here you can see that plastic stent in that gap between the gallbladder and the bowel wall. So the unmet need was we needed tools to prevent leak and perforation. And firstly, we needed a transluminal anastomotic stent that should be lumen-apposing, a LAMS, and it needs to seal off the tract so we don't have leak. But also we need an exchange-free stent delivery system. Seldinger works for the radiologist. It doesn't work for us because of the additional hurdles that we have using that technique. We want to access the target lumen with a stent-loaded catheter and then immediately deploy our anastomotic stent. In other words, we want to eliminate over-the-wire exchange. We've been using tubular stents off-label for transluminal drainage for some time, but there is no lumen-to-lumen apposition. The ends project into the lumens, which can cause trauma, injury, bleeding, even perforation. If we use plastic stents, they have a small diameter, so there can be leak around the stent. If we use a SEMS, it may seal off the tract, but these are prone to mal-deployment and migration. So the LAMS concept was born in 2008. This is from the abstract when I filed the provisional patent, a device whereby two luminal structures in the body may be drawn toward each other. You can see that in the drawing here. The two walls are drawn towards each other, and a fluid conduit is formed in between. Now, this is how I first envisioned a LAMS. It had flanges that curl back on themselves, and it produces this very soft shoulder to minimize tissue injury. Shortly after filing the intellectual property then, I started the company Xlumina, founded in Mountain View, California. This is in 2008. Xlumina means across lumen, so it was the world's first transluminal endoscopic company, and the motto was go beyond, advanced transluminal therapy. And here are the initial group that I worked with. And after we received funding from venture capital to start development of the LAMS, well, countless hours were spent with the engineers in this room here with benchtop prototyping. So we established goals and the challenges to meet those goals. We want lumen apposition, but we want to avoid ischemia. It should not be excessive. We want to resist migration, but the LAMS should be removable. It should be compressible within the sheath, but after we deploy the LAMS, it should resume its original diabolo shape. So we went through multiple different prototypes, embodiments, iterations, but finally this was the winner, the AXIOS, which is an acronym for axial ostomy, AXIOS, with 4 key features. There's a self-expanding nitinol mesh, anchoring double-walled flanges, a short saddle, in this case originally 1 centimeter, full silicone covering. And you can see it took 4 years from the filing of the concept for AXIOS, for this particular type of LAMS, until finally the patent office granted the patent. Now, the exchange-free delivery system is, I believe, more important than the LAMS itself, because that's really the first stages where leak and perforation can occur. And the challenges are firstly, we have difficult double wall penetration, and cautery is often required. The problem with cautery is it burns a hole in the wall, and it can be an unforgiving hole because it will not spontaneously close, and it creates collateral thermal injury to neighboring tissue, and the displacement of the target from the bowel wall. So again, working with the engineers, we went through multiple concepts, and I just want to share with you some of these concepts just so that you have a flavor of the innovative spirit. So the first concept was a multi-layered dog bone balloon. So we have 3 layers. Layer 1 is the puncture needle, layer 2 is the dog bone balloon catheter, it dilates and has that dog bone or diabolo configuration, and layer 3 is the SEMS mounted on a catheter. So this video shows you what this concept was. We advanced the balloon over the puncture needle. We exchanged the needle for a wire. Now we inflate the dog bone balloon across the wall. So we're across the wall, and we will then get the dog bone configuration. And we advance the SEMS over the dog bone balloon, and then we inflate the balloon so that the SEMS takes on that diabolo configuration. And then we remove the delivery system. So that was the very first idea of how we might be able to create this exchange-free platform. Well, we did animal studies, and it really didn't work. So we had to go on to concept 2, which is a multi-layered switchblade trocar. Now remember, we're trying to avoid cautery because it is unforgiving, and we thought if you do have leak, the hole is not going to close. So we came up with this trocar concept here. It opens up to 3.5 millimeters, large enough to allow us to easily pass a 10 French catheter, delivery catheter with the LAMS. So layer 1 is the switchblade trocar, layer 2 is the balloon catheter for wall retraction to keep the walls in that position, and then layer 3 is the LAMS mounted delivery catheter. So here you see in this cartoon how that works. We advance the switchblade trocar. The switchblade opens up as soon as it exits from the catheter. We inflate this balloon at the end, and then we snug up. So we bring the wall of the gallbladder, in this case, in apposition. Now we advance the delivery catheter, and we deploy the distal flange, knowing that our balloon is keeping everything nicely together, and then the proximal flange, and here you see the stones nicely flowing through. So that's a beautiful cartoon. But unfortunately, in the animal lab, this also proved to be very cumbersome, and we actually had some significant bleeds from this trocar, switchblade trocar, and we decided to abandon that. We came up with this multi-layered cutter blade dilator, so another concept. The trocar tip is here, the basket anchor, so this is like a Dormia basket, really, also functioning as an anchor. Then we have this cutter blade dilator that you see here, and the idea is that this cutter blade, this blade will then create that opening that's large enough for us to now deliver the catheter with the LAMS mounted on it. So we have layer 1, anchor trocar, layer 2, cutter blade trocar, a dilator, and then layer 3 is our LAMS mounted catheter. So you can see that this requires multiple layers to progressively, incrementally dilate up the tract large enough so that we can get, in the end, our LAMS in place without doing any exchange. So at no point do we risk that we're going to have leak or perforation. Well, that also didn't work. It was too complicated and simply too costly. So finally, we realized we had to use cautery, but we wanted to modify the cautery because we knew that the cystotomes did not work. We had to modify the concept of cautery. So we came up with the concept of electrocautery-enhanced. And what enhanced means is we have these micro wires that run along the tip. So we don't have a ring around the circumference. We have these micro wires, and they consume only 3% of the total surface area. We get a maximum cutting effect and a minimal coagulation effect. So really this acts like a surgeon's scalpel. And there's a bougie-shaped nose cone that's made of ceramic, hard ceramic. So this is how this looks, so that we can do the electrocautery-enhanced puncture, then deploy a distal flange, and then deploy our proximal flange, all without having to do any exchange at all. So this proved to be the winner in the end. Now, fortunately, endosonographers were already used to an operator-controlled delivery system for FNA. They were used to lure locking their FNA needle to the biopsy port, and so we decided it would be an easy transition to make this operator-controlled. And we thought operator-controlled is important because there really is no room for error here because we're straddling a very short segment of just 1 centimeter. It needs to be one operator, one hand, one device, one puncture, and one layer. So you can see
The denominator here is 1, and I even we talked about calling this the OB1 delivery system because we were all Star Wars fans. But we ended up just leaving it as electrocautery-enhanced, but I do like the OB1. Now, we came up with this handle design, and I have to say in retrospect, you know, the handle looks the same as our original 3D printed handle that we had, and it has really stood the test of time. And in fact, you see the X-Lumina logo here, but now it's been replaced with Boston Scientific, but it's the same handle. So I'm very proud of this handle that the engineers and I came up with. It has indeed stood the test of time. So let's deconstruct that handle for a moment, because that handle is so critical, the function, in terms of, as Takao said, safety first for the patient. So we have two hubs, a black and a gray hub. The black hub advances and retracts the sheath. Now I put that in quotes because technically it doesn't really do that, but it does that provided that you have the inner catheter and the outer catheter coupled together. Then it does that. And the gray hub here deploys the flanges. There are two locks for the black hub and the gray hub, and this additional yellow safety pin. That yellow safety is so critical because it ensures that when you start the procedure, the black hub and the gray hub are coupled. So you have to remove that safety pin if you want to uncouple the two. And then we have the 4 steps, and we even printed those 4 steps on the handle themselves just in case the endosonographer gets flustered and forgets. So we advance the black to puncture, we retract the gray to deploy the distal flange, we retract the black to snug up to the wall, and then we retract the gray to deploy the proximal flange. I'm sure you're all familiar with those steps. The locks are the key to safe deployment. So the gray lock here is what keeps the sheath and the inner catheter coupled. This allows the black hub to advance the sheath into the target, and it also allows the black hub to retract the deployed distal flange, like a retractor, to the wall. The black lock is what prevents any movement of that inner catheter. The LAMS is mounted on that inner catheter, so there's no movement during flange deployment and during flange retraction. So these locks are so critical for the safety. There is no room for error, and that's why we incorporated a 2-stage release of the distal and proximal flanges independent of one another. And we wanted to make this literally idiot-proof, that you could be sleeping and it's going to work. So in stage 1, we released the distal flange in the target. As you probably know, you just pull back this gray hub, and then it makes a click, and that click is an auto-lock function. So now you don't have to think about locking, it will auto-lock for you, and the distal flange is now deployed in the target. In a completely separate step, you deploy the proximal flange. So you have time to think and adjust your position. You're going to snug up the distal flange against the wall, and then you release the proximal flange in the bowel lumen under endoscopic guidance. So the LAMS, this is the term we use, but I have to honestly say my preference would have been anastomotic stent, because that's what we're doing. That's what's unique about the LAMS, that we're able to create an anastomosis. And this is really sort of the holy grail, what differentiated surgery from what we did. We were clogologists. We were unclogging the lumen. Now we have become bypassologists. The surgeons have dominated the bypass terrain, but now we can create bypasses, and we can create the bypass with ducts, the bile duct, the pancreatic duct, the cystic duct. So these are all variations of how we can bypass the biliary pancreatic system. And the GI tract, you heard from Takao how we perform gastroenterostomy and enterostomy. We're extending the reach of the interventional endoscopist by using the LAMS as a port for direct transluminal therapy, whether it's pancreatic fluid collections and performing direct endoscopy-controlled necrosectomy, the gallbladder, where we can perform lithotripsy, stone extraction. We can perform polypectomy. I've done EMRs, and I'm looking forward to my first ESD in the gallbladder, removing lesions. And then, of course, if you have a patient's post-gastric bypass, we can perform what's called the EDGE procedure. So what is the future need? What can we look forward to? We can look forward to a new frontier of dedicated transluminal accessories. And really what Exlumina enabled, it was the first company that had a vision of extending the reach of the endoscopist across lumens. So we can go beyond the gastrointestinal tract, and now, just like ERCP, we need the accessories to allow us to do these procedures safely. Thank you very much.